that's not fresh thing, say, well, you better give me the fresh thing.
For those that are talking in the back room, I can guarantee that Teresa will be after you after this event to make you come in and get in and sit down. As an introduction, my name's Jerry Madden. I was the former chairman of the House Committee on Corrections from 2005 to 2009, and again 2011, 2012, and did a few things in corrections that changed some things in the state of Texas. Lawrence, good to see you, buddy. And I'm proud to be a senior fellow for Right on Crime, amongst other things that I'm doing in criminal justice things nationally. We have today, first of all, our first speaker, our first panelist is Michael Durden. Michael is the Executive Assistant Chief of Police for the Houston Police Department. As most of us have heard and seen in the past, he's an energetic professional with progressive leadership experience and has got a great deal of tenure in law enforcement, something like, what, 30 years? Okay. He has experience in a variety of areas, including administration, investigation, leadership, law and public policy, and community development. He started with the Houston PD just under 30 years ago in 1985, and he has an executive responsibility of the parole operations, traffic enforcement, apartment enforcement, and the mental health division. We're glad to have Michael here today to be our first panelist.
Thank you.
Good morning.
That's not going to work. You better put it right here. Put it right here, Michael.
On behalf of Police Chief McClellan and Mayor Parker, I want to thank all of you for inviting the Houston Police Department to participate in this. But I also want to apologize in advance. Normally, we don't wear our dress uniforms to events, but we actually have a funeral for a law enforcement officer at about 11 o'clock, and unfortunately, I have to go to that. But I think it's really, really important because from the perspective of the Houston Police Department, the real star of our effort to work with folks who are suffering from mental illness and develop and ensure that we have a compassionate and appropriate response to this issue is a very good friend of mine, a person that I work with on a daily basis, is Captain Wendy Bainbridge, and I'm going to ask Wendy to stand up. And she's not going to want to stand up. But, so, Wendy will be here available for questions if you need anything to expound on what we're doing and why we're doing it. But from the perspective of the Houston Police Department, being a local law enforcement agency that is committed to this process, the single biggest issue for us that we see with respect to dealing compassionately with folks who suffer from mental illness is the lack of bed space in Harris County, and not only in Harris County, but throughout the state. And the reason why that is the most prevalent issue for us is, although I think we are a shining example that in dealing with this issue, law enforcement is not entirely the blunt instrument that it used to be. But unfortunately, when there is a lack of capacity in the overall system to where you don't have bed space or you don't have other professionals who can respond to these issues, in a number of cases, you still have law enforcement as the primary response to persons who are suffering crisis. And some of us, despite our training and despite what we do, are not very well equipped to handle that. But most importantly, when we do address the situation and we are capable of handling it in a manner that is compassionate and consistent with human dignity, if we don't have anywhere to take them, the alternative is to take them to jail. Now, our response protocol provides, since probably 2004, we've had over 1,000 officers who are trained in crisis intervention training. Everybody goes through it now. In addition to that, we have our dispatchers who are trained to try to recognize the calls for service slips that are focused on a person who may be suffering from mental crisis, and that way we can get the appropriate persons there. we created a mental health division in which Captain Bainbridge is the leader of that division, where we have dedicated officers who are assigned, when possible, to handle the bulk of those calls. So when there's a call for service involving a person with mental crisis, we try to get somebody there who has training and experience and education and a demonstrated ability to exercise compassion. We try to get somebody to respond to those situations. But here's the rub. Last year we had 30,000 calls for service for persons who are either in a mental crisis or related to mental illness. 30,000. We have a chronic consumer stabilization program that is assigned to the mental health division where we have officers and MHMR clinicians that we team up where we try to get them to the scene of these incidents so they can assist in handling these incidents in a compassionate and humanistic manner. But there's only 24 of those. 30,000 calls for service, only 24 of those people. And the Harris County Neuropsychiatric Center is full most of the time. It's on drive-by on a daily basis. And that's not their fault. That's a lack of capacity in the system. So even when we get trained personnel to the scene and we get dedicated personnel to the scene, we don't have anywhere to take them other than to a jail. And we all will hear from folks who represent the jail staff in Harris County later. They do an excellent job over there, but they're stretched to capacity. So from the perspective of the Houston Police Department, our number one goal is, as we've done in prior legislative sessions, is to try to assist all of the stakeholders in this to increase the capacity for bed space, to increase the capacity for outpatient centers, to increase the capacity and training for law enforcement officers across the state, to get the additional training and education that we need in order to provide humanistic services to a population that is severely in need. It is important for us, and we stress all the time to our police officers, that people don't call the police all the time because they want to see the police. People call the police. Have you ever wondered why firemen are really, really, really loved and police are not very liked very well? Because when you call the firemen, they come to do what? Rescue. They're either going to put out the fire or they bring in medical attention. You call the police because it's the only other agency that's open on a 24-hour basis, and we have told the community for 100,000 years, if you call us, we will come. And then we set up this artificial evaluation in the system that talks about police response time. Well, you know, the police got there in less than 5 minutes. And they say, well, the police response time is good, and that's a measure of our quality of service. No, it's not. The measure of the quality of service is not how fast you get there. The measure of the quality of your service is what you do when you get there. So in the area of dealing with persons with mental illness and suffering from mental crisis, it's still the commitment of the Houston Police Department to provide the most humanistic services that we have. They have officers who are committed to getting there and making a real difference in how those persons are treated in the system, but also treated by our officers. But most importantly, the most thing that you can do to help us is give us somewhere to take them. Because taking them to jail is not a viable option. So thank you, and Captain Bainbridge is here to address any questions that you have, and I'm really, really sorry to have to go out, but this is really, really important to us. It's really, really important to Captain Bainbridge and the persons who work for us, and it's really, really important to the Houston Police Department. Thank you.
Wendy, you're going to have trouble following that one up. The next one, you better watch out, because next person on our list is someone I've known over the years in all of her aliases and other names that she may have had in the past, and that's Dr. Teresa May. She's the director of the Harris County Community Supervision and Corrections Department. Dr. May has 17 years of experience in criminal justice and has worked extensively in the development, operation, implementation, evaluation of a number of evidence-based programs in criminal justice and problem-solving courts. She's a licensed psychologist and serves as an expert trainer in evidence-based practices both nationally and across the state of Texas. She led the statewide initiative to validate and norm the new Texas risk assessment system that is currently being implemented across our state. She serves on numerous statewide committees and provided testimony regarding policy and funding issues related to criminal justice programs to the Texas legislation. Now, that's a minimal statement about Teresa. Okay. I can tell you that as chairman of the committee, there were several people when we came in and did most of our major changes that we did in the criminal justice system, particularly in 2007. There were several people that we certainly relied on. Judge Cosper's back there. She was certainly one of them that was in the room with us many, many times doing stuff. You can clap for her. She was great. But Dr. May, under one of her other aliases at the time, was there also with Dallas County. And she came in and talked to a chairman of a corrections committee who basically talked engineering and numbers and facts with him, statistics and data, which is what he listened to. And so I will tell you that a lot of those ideas that she brought in and have become part of major pieces of things that we did in legislation throughout the state of Texas. And she deserves a lot of credit for being part of that team. So I'm honored to have my friend Teresa May.
Well, I'm kind of afraid to talk right now, but that's a really nice introduction. And it's always nice when someone's eyes don't glaze over when you start talking about data. And I have to say that Jerry Madden is one of those individuals who actually get excited about it. Everybody else is like, no, not again. Carrie Wellebaugh, where are you? The director for TDCJ CJED, which is our oversight agency for probation, has worked really hard with us in the development of a new risk assessment tool. It was her leadership that really made this happen. I want to make sure, if you haven't met Carrie, you talk to her, because we are in the process of implementing a great new risk assessment tool, and it hasn't changed in Texas for 30 years. So it better be good, and it is. And it's something you've heard a lot about today. We're excited about it. You know, my goal, or my job primarily when it comes to pretrial jail, is to help people succeed once I get them. And my best impact on the jail is to make sure that I do everything I can to keep people from coming back in. So we all know that there's a door, but it's a revolving door, and you've all heard about it for a long time. When we look at people with mental illness, and I'm a licensed psychologist, so I've seen it all, I think it's important for everyone to understand, the population, just like everybody else, divides up into group, and risk does matter. So not only do we have to look at the mental illness itself and understand what's going on with that person, we need to do our same risk assessments that we're doing on our regular probation clients and frankly other individuals in the criminal justice system on the mentally ill as well. Now, you have to have them in a state you can actually talk to them, right? And they can communicate and you can get valid information, which is some of the things that we work through with our mental health partners. But what's important to understand is just getting those individuals medication. It's important. We have to do it. But those individuals that are at higher risk to continue involvement in the criminal justice system, those individuals need medication, but they also need intervention. So for those of you who don't know a lot about risk assessment, there's about 7 things that consistently predict failure. And some of them are who you hang out with, who's around you, family, marital, housing, where you live, what's going on there, stability, drug problems, substance abuse is an issue, and how you think. Criminal attitude is also an issue. What the research shows us is that the mentally ill population in criminal justice really does divide out. There are low-risk individuals, which I think Harris County's done a phenomenal job with Captain Bainbridge, and she needs more support for anybody in here that has money. That's a phenomenal operation to redirect lower risk individuals. They deal with some situations that are scary and do a phenomenal job. But an important thing they're doing on the front end is trying to divert individuals that don't even need to enter the jail, that are low risk. They don't really have a lot of stuff. They don't have anywhere to go. That's one group. But there's another population that continues to revolve in and out that are also substance addicted. They have drug problems, serious drug problems. They have peers that are also in trouble, criminal trouble. They have difficulty at home. They have a whole host of other factors that we have to focus on. So one of the things I've spent my time really working on with this population, and when I get these individuals, I do want to know as quickly as possible what's going on there with them mental health-wise. So, you probably heard a little bit about it earlier, but I also want to know what their risk level is. I want to know how many of those criminogenic factors they have. And what we know from the research is the same things that predict rearrest in our general probation and offender population predict rearrest in the mentally ill population. So you have two goals. You want to get their mental health issues addressed, but you need to address the drug problem and the other things going on. What I encounter are families that are exhausted. They've been trying everything they know at times. There are some people who don't have family, but it's important that we target those issues. And that's what we focus on in probation. We want a timely assessment when we do get them. We want to identify mental health. We want to partner with our local mental health authority and trying to get them treatment, which there's a lot of challenges just because we're huge and the system needs to evolve, and criminal justice involved individuals are a little bit different in what they need, and we want to target those criminogenic risk factors. So I'm going to leave it at that for what I'm going to say right now, because I think we can get to some other things as we do Q&A, but that's what our focus is when we get them on probation, and we do have some great resources to do that. Hand off to Clarissa, or whoever Jerry said's name. And
one of the things that has happened over the last particularly decade in criminal justice is that engineering data has become extremely important, and data-driven items have become a major factor, which they weren't 10, 15 years ago, and that was part of the things that have been major changes that have happened in our criminal justice system, particularly here in Texas since our 2005 period when we started really using what in fact was data-driven and asking the question, well, does it work or doesn't it work? Why does it work? And let's put our emphasis on and our resources on those things that do work, and forget those practices that we were doing that may have sounded good, may have felt good, but didn't really work. Clarissa Stevens is the Deputy Director for our Harris County Office of Criminal Justice Coordination. And one of the things we found in doing stuff around various states is that it really is important to bring in all the players, all of them in for coordination. Her focus is on using data-driven analysis to identify the underlying causes for certain populations, such as individuals that have mental health and or recurring or co-occurring substance abuse issues and are homeless to recidivate. What drives the recidivism rate? She has worked to devise and implement programs and processes to improve outcomes and prevent costly recycling through the criminal justice system and other crisis-driven public services. Clarissa has participated on planning and implementation teams for the Homeless Continuum of Care, the Harris County Felony Mental Health Court, Harris County Mental Health Jail Diversion Program, the Primary Care Innovation Center, the MHMRA Jail Diversion Task Force, and various other prevention, diversion, and reentry initiatives. That's a lot of things to be on. I'm not sure how she gets all the time to do all the other stuff, but Clarissa, thank you. Come on.
Thanks. I'm going to have to bring some notes because I don't want to forget anything. There's so many good things going on in Harris County. But before I start, I just want to remind everybody how big Harris County is. The unincorporated area of Harris County is larger than the city of San Antonio, and we have Houston sitting right in the middle of that. So I just wanted to kind of build off of what Chief Durden said, and the Sheriff's Office also has CERT teams. They have 9 CERT teams, and we have 3 more in the works. Another kind of preventative program that started in April of 2013 is the Houston Recovery Center, which Wendy knows a lot about. And they've admitted over 8,700 people since that time that have been diverted from a public intoxication charge, and a lot of those people have co-occurring disorders. What I want to talk about, though, is what happens in Harris County from the time a person does get arrested through their first court appearance, and just how we identify mentally ill people and how they move through the system. I also want to remind you that Harris County has over 100 arresting agencies, so we have a lot of education issues out there. After charges are accepted and within a few hours of booking into the county jail, a person has a probable cause hearing. Probable cause hearings in Harris County happen 24/7. At that time, a court is assigned, and the next morning, if the person's been booked by 10 p.m., they're going to be in front of their home court. Before a person gets housed and at booking, there are 3 chances to identify a mental health issue. The first is during the pretrial interview. The second is at the booking deputy. The booking deputy will use a screening form for suicide and medical and mental impairment, which is printed for the intake nurse if there are any affirmative answers. Before classification, each detainee, whether they're there on a new charge or if it's a parole violator or there's a warrant from out of county, will go to through the intake nurse, and the intake nurse has been trained to ask questions that can identify mental health issues. In addition, the Sheriff's Office has a really robust EMR system and a mental health database that has mental health history in the jail back to 2001. That intake form is populated with any information that we already know on mental health, so the nurse knows. There's about 290 people that are booked into the Harris County Jail every day, and an average of 55 of those are sent directly to the mental health clinic before they go to classification. That's about 22% of the people that are booked into the jail. On Wednesday, there were 8,488 people in the jail, and 2,212 of those were on psychotropic meds. We do a really good job of identifying people and getting treatment started that night, as soon as they're booked into the jail. Our jail has 296 beds for acute and subacute mental health needs and provide group therapy in those units, targeting psychoeducational skills, substance use, and wellness recovery. Let's see. And another thing that the sheriff has done to help with continuity of care, in 2012, a process was implemented to provide persons without an ID with a picture former inmate ID card that's recognized by Harris Health, MHMRA, the Houston Council on Drugs and Alcohol, the AIDS Foundation, and numerous area shelters. It's also accepted by DPS as a secondary identification for obtaining a Texas ID. This year, to date, 675 of those have been printed and issued as people leave. The Healthcare for the Homeless Jail Inreach program began in 2007 and has served over 1,700 mentally ill homeless individuals and successfully linked over 1,100 of those to services. Judge Patrick mentioned about the orange sheets. What happens every night at midnight, there's a match with MHMRA's Anasazi system with the mental health database in the jail. And if a new person has been booked into the jail and is identified, then Anasazi sends back diagnosis information to the sheriff's office. When the dockets are created, I think around 2 o'clock in the morning, there's an electronic orange sheets that's created for everybody on a docket that has the information that he mentioned. In addition to that, there's a list of people that are in jail that's created that are on meds so that the sheriff's office can make sure they get their dosage before they go to court so that no meds are missed. And there's also an algorithm that's performed for the public defender's office that identifies high needs indigent individuals that they will be able to represent that day in the misdemeanor courts. On Wednesday, there were 215 of those orange sheets created for our courts. Both the public defender and the DA's office have mental health divisions. And also this year, the public defender sponsored a series of CLE events for defense attorneys and prosecutors that wanted to obtain additional expertise in mental health. Throughout that series, there were 300 attendees, 21 people that attended 75% or more of the series took a test and passed it that gave them a designation of competency in representing mentally ill clients, and those have been flagged on the appointment list. The district attorney's mental health division has 5 lawyers, 1 investigator, 1 paralegal, and 1 assistant. They work primarily in the felony courts. They have plans to train the 15 misdemeanor chiefs and hire a felony chief prosecutor to help all the chiefs recognize mental health issues and whether or not to call in the mental health division. The public defender has 5 misdemeanor lawyers with plans to add 2 next year, and 2 felony lawyers with plans to add 1, 2 investigators, and 2 social workers in their mental health division. Harris County has quite a few specialty courts, and all the specialty courts have people in them that have a mental health issue. But we do have 2 felony mental health courts. Since April of 2012, there have been over 250 referrals and 103 participants. All of those met criteria for Texas priority population diagnoses, and 80% also met criteria for co-occurring substance disorders, which I think we haven't really talked too much about how we need to emphasize the importance of combining all of those treatments, mental health, substance abuse, and physical health. They generally all roll together, and we need to find a way to blend that. There are also 2 district critical time intervention mental health court dockets for people on probation that are at risk of revocation. There's 54 people on those dockets. There's a competency restoration docket for people that are in the process of being restored or incompetent and unlikely to restore. Currently, that docket has 211 people, and about half of them are even in a facility on recommitment, in a facility waiting to be restored or waiting placement. And since that docket was established, 590 people have been restored. I know everybody's interested in hearing what's going on with the mental health jail diversion pilot, affectionately known as SB 1185. What we've done is we've identified over 3,000 people that have had 3 or more bookings in the last 2 years that meet the qualifications for that program, or we think meet the qualifications. On a real-time basis, we match that list with people that are in jail and provide Dr. Hicks, who's the director of that program, with that. She has access to that list at all times, and they use that list for referrals in the jail. At this point, there have been, there's anywhere from 450 to 500 people that are in the jail at any given time out of that 3,000. Currently, they have 97 people enrolled. 54% were enrolled while they were incarcerated. Those are people that have already completed their cases, and they were screened and wanted to be in the program. 22% are referrals from the community at large, and another 25% were referred by MHMRA as current clients that needed that extra help. There's currently 3 county criminal courts that are participating in a pilot with that program, and I think my time's up, so I'll be happy to answer any questions. I brought a bunch of data.
Thank you, Clarissa. We also have now another speaker who I know can carry on with the language as well as Dr. May has done and continue to tell us all the wonderful things that are going on. That's Dr. Andy Keller. He's the Executive Vice President for Policy and Programs at the Meadows Mental Health Policy Institute. He's a licensed psychologist with more than 20 years of experience in behavioral health policy, with particular expertise in health and human services integration, behavioral health financing, and best practices. His work centers on helping local systems implement evidence-based innovative care, as well as helping local state governments develop the regulatory frameworks and financial mechanisms to support them. And let me say that both of those are extremely important to make sure you've got the regulations that are in the right place, doing the right thing, and also that there's the financial support that's going to be available for doing the things and doing them correctly. Andy's responsible for all the behavioral health policy work of the Meadows Institute. They do a great job, and I'm proud to call him a friend and glad to have him come up, Andy.
Jerry, I'm supposed to tell you hello from your friend Phil Ritter, too, at the Institute. You go back further. I've only been a Texan for 5 months, so I hope you can forgive me for that. I haven't quite migrated my football allegiances yet. I'm still a Seahawks fan, sorry, but it's a good time to be a Seahawks fan, which is not something you could have said for very much time since 1976. So it's great to be here today. And, you know, and it's a pleasure to be sort of the token, I think I'm the token mental health system representative, right? Because I think everybody else is in the correctional system. Is that right? I mean, you're a psychologist, Teresa, but you work
that kinda
in the
counts.
correctional system. And I'm going to ask my friends, well, actually not quite yet, my friends in the mental health system who are in the audience today, I'm going to ask you to cover your ears here in a sec. But I need to tell you that, you know, one thing I can do as a new Texan is I can still hopefully talk as sort of like a person who talks, you know, comparing Texas to the rest of the country. And maybe I still have some credibility because you don't have credibility when it's your hometown. You know, you've got credibility when you come from outside. So I'm still coming from outside. And I'll tell you from outside that y'all have the building blocks, actually not the building blocks, the cornerstones and foundation laid in Harris County and to some degree in Texas to have successful full-scale diversion more than I think any other place in the country. I mean, the people you have here, that you have here in Harris County, are among the top leaders, the top people doing research on risk assessment. I mean, Teresa snagged 11's here, and Teresa's here. You've got a DA who's friendly. You've got judges like Judge Patrick. You've got the people here to do the best job in the country with diversion. Sheriff Garcia, one of the very first people I talked to when we were forming the Institute to say, hey, what do we need to do around mental health? Chief Durden, you know, running state-of-the-art national best practice crisis intervention teams. So clearly the issue, the problem, about bringing things to scale is not in your correctional system. So this is where I need my friends in the mental health system to cover their ears for a sec. The problem is in the mental health system. And I'm here to say it's the mental health system. It's not the individuals here. You have some of the best people in the country working here in Harris County. Awesome Shaw at Harris Health, Rose Childs at MHMRA, Dr. Knox at MHMRA. You've got outstanding individuals, state-of-the-art practices, the 1185 project that's going on. You're doing some wonderful partnerships. And, you know, a lot of people like to say, you know, the system is broken. You ever heard that one? The system's broken. One of my least favorite sayings, because I don't remember the time that the system was not broken. One was this time when we dropped the system, it shattered, and it became what it is today. We've never actually got the system working. And so when I say that the mental health system isn't working well, it's not because people are doing things wrong, it's because we haven't figured it out yet. And the thing I guess I also want to tell you here is that your mental health system, and we're, by the way, trying to figure this out right now. We're under contract to the Institute to help Harris County, to help MHMRA of Harris County figure out kind of what the strengths and opportunities are within the system, what are the opportunities for getting better, for moving forward, and we think one of the big areas is in this area. And it's not because you're doing worse here than other parts of the country. It may actually be that you're doing better than most places in the country. It's just that none of us are doing a particularly good job. So what do we do? How do we have a framework for this? Well, we think, what I'd like to have you all think about is not so much what is the next super cool thing that we do here in Harris County to kind of incrementally take our diversion programming to scale. It's how do we actually take it to scale? How do we sort of shift our vision from, you know, adding another court, adding another CIRT, adding another, you know, slots. I mean, you know, when Clarissa was just talking about the folks through the new 1185 program, that's about 10%, right? If I did the math right, it's going to serve about 10% of the people that you've got there. So we've got 90% of the people that may have these needs that we're not going to be able to serve. Chief Durden was talking about we're going to, NPC, the Neuropsychiatric Center, is one of the state-of-the-art sort of models. It's right there at Harris Health. I mean, it's right by the hospital. It's kind of co-located. It's got all the great features. But most days, as he says, it's on diversion. You're diverting thousands of people a year through that. But how do we kind of take things to scale? And I have to say, it's not building more beds. And now it is having more capacity, like Chief Durden was saying, at NPC. But building beds isn't the secret, because you've got about 100, 200 new psychiatric beds coming on in your community. You've added some over the last year. You're going to be adding more. So clearly that's not the case. It's not simply giving more money. I mean, I'm not going to say money is not a factor. My boss, Tom Luce, likes to say funding is not irrelevant. And I think that's an excellent way to talk about funding. You don't want to lead with that, but it certainly is not irrelevant. But you have $110 million more, actually probably more than that, more like $120 million or more today being spent on an annual basis on mental health in Harris County than you did 2 years ago. Did you notice that? Did you notice $110 million more of impact in terms of reducing needs? My guess is you probably noticed some, but you're not noticing that much. It's not a lack of the right people. So what is the thing? I'm going to tell you that I think that the thing that's lacking is a systemic perspective. There are system barriers here, and I want to talk about just 3 of them. And one of them was talked about, I think it was Sheriff Garcia that mentioned it this morning, is that the suspension of Medicaid benefits. Now, I'm not going to get up here and tell you that we need to do more Medicaid in Texas. If someone asks me a question, I will go on about that. But what I'm going to tell you is if we decide that we're going to give someone Medicaid, and we don't give that to very many adults. We give it to a lot of kids. We don't give it to very many adults. If we're going to take the time to give someone Medicaid, the least we could do is let them keep it if they get in trouble, and not make them go through all these hoops again. Not because you don't even have to be a decent person. You just have to not be stupid. I mean, it's a waste of resources to make these folks go through that again. So if we could get behind that and to allow Medicaid benefits to be suspended a reasonable amount of time, actually as long as we possibly can, because we'd like people, if they're still eligible, to be able to keep that when they come out, because we'd like to keep them out. So that's one very minor one. The second one I'd like to say, which is a little bit harder, but one I think we can do this year, is to performance metrics. Right now, there are no meaningful performance metrics related to diversion in the mental health system. And there are opportunities to do that. The Sunset Commission passed DSHS Recommendation 2.3, which calls for a comprehensive review over the next 2 years of the performance metrics related to mental health. HHSC Sunset report that was just voted unanimously earlier this week, in 6.1, which was one of just a couple recommendations that my boss, Mr. Luce, who's on the commission, put forward, it requires HHSC to align its metrics, particularly around crisis intervention for the LMHAs, but also for the DSRIP projects, the 1115 waiver projects, that's where that $110 million came from, and also for the Medicaid MCOs. We don't talk a lot about Medicaid MCOs, but you know the Medicaid system serves more Texans with serious mental illness than the local mental health authority system. I mean, your MHMRA serves a lot of people, does great work, but statewide, and I don't know how this parses out exactly for Harris County, but I think the statistics are probably as true here as anywhere, more people are served through your Medicaid MCOs who have serious mental illness. How do we get these systems where we're spending hundreds and hundreds of millions of dollars every year to actually work together and to come together around performance metrics around behavioral health? And what do I mean by performance metrics? I mean the kinds of things that Clarissa and Dr. May were talking about. You get a tremendous amount of data here in Harris County. You know the vast majority of people who have mental health needs who come through your system. What we need to do is we need to boil that down to some metrics. And let me give you an example of what we were doing with that. We're working right now in Bexar County with the Justice Center, with Tony Fabello and the folks of the Council of State Governments, on a jail diversion pilot there where the aspiration is to go system-wide to have 100% of folks who can be diverted. And what we're doing is we're taking a little bit more robust of a screening tool than what you're using right now here. It's not just suicide, it looks at some other things. It's not as robust as the assessments that Dr. May's group does. It's sort of in between. It's a screening tool that has a little bit more information, and we're using that and we're crossing it with the TRAS against risk, and we're identifying groups of folks, and we're trying to slot them then into different types of diversion. If we could identify all those folks and have a metric for that, guess what? You could hold your system accountable for it. And it sounds like a little thing, but it's a little thing that could be a really powerful lever to start moving people. And everybody's going to say, well, the data's not reliable. Of course it's not reliable, but you know what gets data really reliable? Is using it. You start using data, people get really good at it. And of course they game it. And of course they do. We're human beings. But you know, people game, they game weights. People like they're measuring things. People do that all the time. So we have to better calibrate, better have incentives and oversight of that. But we think that's probably one of the most important opportunities. So that brings us then to the third reform, and that is something you need to do in the justice system, is you need to then standardize these metrics. And I think you've got a great opportunity here. Let's live in Harris County. We've got a big part of the state done if we standardize it here in Harris County, and then we can model the rest of the state on that. We have to make sure that it works in places like Hudspeth County, which has a lot fewer folks than you do and a lot of other issues. But a lot of different issues, but I think we can do that. So I mean, that's our kind of policy agenda this year, is to get those performance metrics in place so that we can basically get things out of the way, because there are good folks in this mental health system. The MHMRA of Harris County, you have a tremendous number of wonderful people. They're doing great programs every day, but their hands are really tied by a lot of regulations, paperwork, requirements that make it very difficult for them to do their job. So we're trying to align around these metrics, and we think if we did that, that would be really helpful. I think, then when we turn more broadly, so, what do we do? So how do you bring that then back to the system? So I told you I don't think the answer is more hospital beds. I'm not saying you may not need more access to hospitalization for certain groups. A lot of those new beds that are coming online are entirely targeted towards commercial folks. Not to say that no folks with commercial insurance go through the judicial system, they do. But the majority of folks who we're talking about and who are repeatedly going through often are indigent. So what is the thing that we want to do? It's basically, we're really good in Texas, and we're really good in Harris County at crisis work. I mean, the CIRT, the MPC, all these cool acronyms of places that help people out. Where we get hung up is keeping people in care. That's where we get hung up. And so the 1185 program is about keeping some of your hardest to keep in care people in care, a relatively small number percentage-wise, but an important group, and I think it's something that can be built on. But if we have these performance metrics in place where we're looking at the responsiveness of the behavioral health system, when you identify somebody, not just in crisis, but in any other need, how well we respond, and then how well do we keep them in care? What do we do? How do we keep them in care? And how do we get some of the things, the regulations out that basically tie the hands of your MHMRA and give them some little service packages that they have to fit somebody exactly in? And the reality is that people don't always fit into nice little boxes. So you got to give clinicians a little bit of flexibility around this stuff. So that's where we're putting a lot of our effort in terms of system development, is how do you build that capacity to keep people in care so we don't overuse this wonderful crisis system that we've developed. So that's kind of where we're at. We'd love to answer more questions when we have discussion, but it's exciting to be part of this. And just so you know, the Meadows Institute is very committed to helping out in this area. And Tom Luce, when he was asking me last year, what are the priorities we should have for the year, I said, well, there's this thing going on in Harris County around diversion. It'd be really cool, but it's Harris County, which is like really big and really hard, because quantity is a quality all of its own. It's harder to do things when you're really big. And Tom told me about his education days. Tom was a big education reformer, and when he passed, you have to pass to play, he took on the cheerleaders and the football players across Texas and told them that they had to have passing grades if they were going to show up on Friday night to the football game. And more importantly, he took on their parents and somehow lived through that. So I got him to feel like we could probably, if we could do that, we could probably take on this just smart justice jail diversion thing. So we're here for the long term, and we're excited about the opportunities here in Harris County.
Andy will hate to know that I was going to name the mental health program here in Harris County as the No Pass, No Play Mental Health Project.
We could do that.
Because I've gone back with Tom at least that many years. We're open for questions now, and if you'd like to, we have the microphone up front, and don't hesitate to come up with this. And maybe I could ask Wendy to come up and sit in here for the police also, because I'm sure that the police department will get some questions as we go forward on this too. I know you're not shy. I know you're not shy. Get up there.
I'm very frustrated. I do misdemeanor cases, and there are a lot of revolving door of mentally ill misdemeanor cases. But probation departments are funded by the state, and people that are
Not all of it.
Well, not all of it, but
Not all of it.
primarily.
Okay.
And people
Some
that are
places.
accused of misdemeanors are often not as likely to take probation because they can get a short sentence. And so I'm interested in whether in Harris County, the assessments that you're doing, we do in Travis County, but it's really for the felony courts. Are you doing anything for the misdemeanor courts?
that's
Because
a
I
great
don't have
question.
that.
Teresa, that's yours.
I got it. We actually just started our first misdemeanor pilot court this week. So for those of you, and I didn't go into a lot of detail earlier, I don't want to get way off the topic here, but what I'm doing on assessment is the research has been overwhelming, frankly, both for felony and higher risk misdemeanors. If the longer it takes for us to get them assessed and get them engaged in the right appropriate treatment and supervision, the more likely they're going to fail. It's a no-brainer. They're using drugs and shooting up and mentally ill when they get arrested. And we put them on probation. If it takes me 3 months or 4 months to get all those assessments done, they're gone. They're back in jail. So I want to put a stop to that. I've done that before, and there's a lot of challenges to it. In my previous life, I did that only on felonies. Well, so what we did is we moved the assessment process up into before sentencing, basically. So it's either pre-plea, pre-sentence, or it's post-plea, pre-sentence. And what we do is if probation's on the table, it doesn't have to be agreed at that point. And I'm going to talk about felony, and then we'll come around to misdemeanor. It doesn't have to be agreed, but it has to be on the table. What the court does, they reset the case for 30 days. Person may be out on bond. What's happening right now with our first 3 pilot courts, there are individuals that are getting a PR bond to get out and get their assessment done. So as a condition of bond, they go get their assessment. The process is designed to do the risk assessment first. And if they're low risk, we're going to look and make sure we have identified mental health and get them engaged where they need to go, but that's going to be pretty quick. If they're medium or high risk or higher end, we're going to do more extensive screening for mental health and substance abuse, and we're going to do the substance abuse and mental health eval right then. It's one stop. The more times you bring somebody back into a building or go get something done, the less likely they're going to show up. So when they get probation, we already know what needs to happen. We know if they need to go to residential. We know if they need to be engaged in outpatient treatment. I know if they have co-occurring problem and I need to get them in my adult diagnosis facility. I'm on top of that case. My previous life where we implemented this program, we saw a 59% reduction in revocations just because we were moving fast. We were on top of these cases. And if you don't move, they're not going to get any better. So we stopped a lot of people coming back in the jail. Okay, that's really important. Now to your question. I did not do that with misdemeanor in my prior life. It's an extreme challenge just because of the volume. However, let me say this. There are high-risk misdemeanor cases. There are a lot of folks that just happen to be arrested on a misdemeanor this time. There are a lot of second DWIs in Harris County. And when I'm looking at these individuals, they have mental health issues. Some of them are mixing drugs with the alcohol. It's a pretty scary situation. So I'm working with my misdemeanor courts here. In misdemeanor, they're much more likely to show up. If they plea out their case and they're put on probation, they're much more likely to show up if the judge says, go get your assessment next door. So what we're doing with misdemeanor, as soon as they're placed on probation, they walk straight over and go through the same process felony is going through. Now here's the cool thing about Texas, and I'm sorry if y'all aren't from there, I got to brag on Texas a little bit. The risk assessment we have just developed, we created a misdemeanor specific version of the tool. Measures the same critical factors, but it is focused on misdemeanor, and it is highly predictive for misdemeanor. It works very well. What that does is that helps me be very efficient in getting them screened and assessed on the misdemeanor end. So that's really important. So my misdemeanor courts, just like my felony courts, have been really anxious to get involved in the new process, and we just started our first misdemeanor court with Judge Brown, Robin Brown, where's Ed? This week. Ed Wells back there, court manager, has worked very hard with me, and we'll be bringing more misdemeanor courts on as the quicker I can intervene and get on top of those cases, the faster I'm going to work. We do have limited funding, you're right, but we're getting smarter, we're working through it. Carrie Wellbob's looking at me right now. She works hard with us. She gets phone calls from me when we need to do things. We're getting as creative as we can. So that's the short answer, believe it or not.
Any other panelists have any long answers?
That's why you love me, Jerry.
Let me say that Teresa, when she talks about her pre-life and her guinea pigs, that was really Dallas County. That's what she used.
Thank you very much. My question was to both Captain Bainbridge and to talk a little bit about what Dr. Keller had said. Captain Bainbridge, your chief talked a little bit about the great resources that are available at the Neuropsychiatric Center for our CERT teams to be able to do those drop-offs. However, the capacity issue there, is a deterrent on being able to fully utilize the system with it. And I know Dr. Keller talked about it's not necessarily a overall bed capacity issue, but in those emergency situations that law enforcement are routinely involved with, hence the mental health division at HPD, is capacity an issue to be able to do those emergency detention orders and to be able to better facilitate the absence of incarceration on it in more of a clinical setting? Because it seems like added capacity to that system, which isn't necessarily a law enforcement one, but is more of a clinical one, would be, it would certainly be very cost efficient.
No, thank you. Thank you very much for the question, because I'd like to clean it up a bit. What we mean by needing more bed space, yes, we do need more bed space, but it would be nice to have step-down care, long-term care that's affordable to keep people out of crisis mode. Right now, HPD, well, last year we had 7,000 emergency detention orders from those 30,000 calls for service that Chief Durden was speaking about. Daily, NPC is on diversion. We have trained half our law enforcement officers on CIT, crisis intervention training, and learning how to handle those type of scenes. But it's had the unintended consequence of a capacity, and it has highlighted the lack of bed space, a lack of care. As a result of that, people are just released, and they're not really taken care of long term. They're not given the tools that they need long term. And so, as a result of that, it backs up on the 911 system, and they get a police officer at their door instead of a mental health professional. And so that's what I mean. Yes, absolutely, we need long-term care. We do. We need step-down care. But the immediate need of crisis intervention training and having more facilities such as NPC instead of the area ERs of the Harris County Jail is absolutely needed. So thank you very much for that question.
Yeah, and I would just fully agree with that. I mean, basically, it's the flow through. I mean, and I'm not going to judge whether there may be 16 more beds somewhere. And also, it's what do you use those beds for? I mean, new hospital beds are being built, but are they being aligned in the way like NPC is? And they're not the only resource, but I mean, the places that basically are law enforcement friendly, so that when they're not on divert, law enforcement comes, they can rely on the person being taken. So I think you've got that great front end piece. You now need to be able to have a system that is, and part of that is untying the hands, frankly, of your local mental health authority, because they have a lot of restrictions on them about, having to do a very select number of evidence-based practices, and having to get the exact number of hours. I mean, there's a lot of micromanagement on their side. When they try to go out and recruit additional providers to be in their network, one of the biggest barriers, and this happens too, the state just let out, they're trying to purchase more hospital beds. Well, the requirements that the state put in place, the paperwork that you have to go through to do that is a huge disincentive, because, they'll talk about how much they're going to pay you, and they'll pay you maybe barely enough to maybe you'll possibly think about doing it. But then when you look at the paperwork you have to do on top of that, then you're not going to do it. So, it's both getting the right incentives, but also untying people's hands and kind of trusting our local clinicians and our local systems to come together. And I have to say, that's probably something that we also need to work on. And I think, you've got Clarissa's group, you've got a great sort of group here. One of the recommendations in this report that y'all should release today is to have MHMRA and the mental health system be more represented in that process and to be there at the table. And I have to say, a lot of times we in the mental health system are not great partners on this, because we spend a lot of time talking with you about the barriers for why folks you all are concerned about, can't come in our front door, and we make our front door sometimes harder than it needs to be to get into. We need to work on that, but I think, being at the table and collaborating is something that we have to be a part of, otherwise we're not going to figure this stuff out.
You guys are in real trouble now. Mark's got a question.
Well, since Dave LeBon asked one, I figured I might. I wanted to ask about, it was a good one, too. I want to ask about the role of civil commitment, including both traditional civil commitment to a residential facility, but also the potential use of civil outpatient commitment, because sometimes we hear that someone is charged or arrested for, obviously sometimes really minor things, it could be criminal trespass, but part of the goal in prosecuting them is to get them treatment. But maybe we'd be better off looking at the ways we could enhance the civil, including civil outpatient commitment, as an alternative to criminal prosecution.
Now, Mark, you're assuming everybody wants treatment, right? So you're talking civil commitment, which is not that easy to do, and I don't know if Wendy, Captain, wants to talk about that end or not, do you? You guys look at any of that?
And, no, at law enforcement, just to let you know what we're doing and the results of our training will help set your response up. When I mentioned 7,000 emergency detention orders last year, 24% had a criminal nexus to them. But only 1% of those 30,000 calls ended in an arrest. And so we already, CIT training is the largest practiced use of diversion now. The Seminole, we have an emergency detention order that the state of Texas has allowed peace officers to have, and of course that's just that one-page form just for an evaluation. We don't do many civil commitments beyond that. I will say of the 7,000 EDOs, emergency detention orders we had last year, 30% of them doctors wanted to keep. Or no, forgive me, 80% doctors wanted to keep. And so about 20% of that 80 after a while went on to get committed. So that is a process after law enforcement is finished and handed them off at NPC or an area ER, then they go on from the process from there. But we don't really have a lot going on regarding civil commitments beyond the EDO.
The only other thing, I mean, I'm not the best person to talk about this, so if there's someone in the room that has more expertise, I'm happy for you to stand up and talk. I have worked, even with individuals in the county jail, where we have someone that's just very, very sick. Maybe they're not to the point where competency is at the point where they are declared incompetent, but they're probably pretty close. We have them in the jail. We have them outside of the jail, even reporting to probation. I have families calling me. How can I get my family member in the hospital? The civil commitment process. So there's a lot of challenges with it. They don't stay long. They're usually right back. I know in the jail, one of the other issues is, and also even among offenders on probation, is refusing meds. I mean, a lot of the folks that are getting arrested and also reporting to us are refusing to take their meds. And that is probably one of the biggest challenges and barriers that anyone has, including our mental health partners. There are limitations, even in the jail. Somebody refuses their meds, you can't automatically force meds. And where's Alex? There's very limited, you are the one that should be talking about this right now. There are very limited number of ways you can actually even get an order to force meds. So, and then the civil commitment, the question is how long they keep them, what happens, and does it answer things in the long run? My other concern is if they're low risk, absolutely, I wish we could look at that more. And they don't have a lot of those other criminogenic risk factors.
Yeah.
If they're not, we definitely need access to get the psychiatric symptoms addressed, but we have to address the drug problems, the criminogenic risk problems, or this will never stop. And that's what everyone needs to understand. And Alex, do you want to add anything about civil commitment?
The only thing I would add is the civil commitment's a creature of the probate courts. We don't currently have a good mechanism that works between the criminal justice system and the probate courts, so that's where that drops off quite a bit.
That leads to one of the things that I was going to at least mention up here was coordination and the fact of how important coordination in your coordination group that you've set up now really is to help do those kinds of things, because we've all seen agencies, groups who will do things that are based on their budgets and not necessarily the best results that we would get for the overall system that we're dealing with. We've seen that many times out there. And if you can coordinate it in such a manner so that the ultimate goal is the best result that you can possibly get for the overall system and coordinate that funding, you will in fact see a reduced cost and at the same time a better result.
Yeah, to me, that's just because to me that really ties to your question, Mark, is that I think that the fundamental coordination and collaboration among the agencies is is a more important factor. I mean, I think the outpatient commitment is one tool, but there's other tools, around motivational interviewing, and frankly, the motivation of your treatment system to want to keep people in care. I mean, if you're working at cross purposes versus working together, and I think a lot of times, we want to kind of make systems, make individuals collaborate, and there's a limit to that. You can probably make people, if you all work together well, not kill themselves. Most of the time you could do that. But to keep people in care ongoing really requires a motivational framework, and it requires partners wanting to work together. And I think that that's what I guess. So what I would say, what we're trying to really emphasize at the Institute is mechanisms whereby local control can be coordinated and then implemented. And by that we mean getting people who often are not on the same page, because there's a lot of, struggles around everybody trying to live their mission out, locally, to get them to align around some common goals. And then if they come up with outpatient commitment to something they want to do, then great. But that may or may not be, I think it's more important the local driven aspect to me in the coordination than the specific tool.
Well, and let me piggyback on something, Mark, and I think this is important as we're going into session to look at what we've historically done in criminal justice. I have a lot of mentally ill offenders on probation that need intervention. We're working with them. We start to see them melt down, get off their meds, get symptomatic, and we know the wheels are coming off. Getting them an appointment real quick is not an easy thing. The wheels are off. There are other times where we're seeing that person, and honestly, if I could get them in a crisis bed, we would have a shot at stabilizing them. And they're willing. They don't have the skills to do it. But there really is, as Andy says, I mean, meshing these systems together, there's not a mechanism to do that. My mechanism is not easy at all. So we end up, trying to work with a system that can't respond. And, something else that's important to understand is, the criminal justice and the mental health system has kind of been meshed together because of the circumstances. I mean, there's a really big need for it. But, our mental health system worries a lot. They don't really like the criminal justice folks showing up all the time. They're not necessarily comfortable with everything that we do, and there's an education process, and possibly, as Andy has said, we really need to look at the system design as to how we can work and communicate better with the criminal justice and mental health system in getting people services at the right time and preventing an arrest or preventing people from having to go to jail.
And that gets into my statement that I made earlier about the financing and the organizing it. And it's important to know where those points are at, whether it be at your local city council, whether it be at your county commissioners court, where that coordination can be done, whether that's at the state of Texas and what we do,
Right,
or
that's
whether
right.
it's someplace else and we need to put some other pressures on additional groups. Yeah.
I'm Ryan Sullivan, a policy advisor with the Sheriff's Office. Kathy Griffin from our office also has another question. So for heaven's sakes, I'm going to try to be brief. Dr. Keller, I
You better get
appreciate...
Kathy up in line, because we've got 5 minutes left. So Kathy, get up in line.
I appreciate everything that you said, because you've hit on every one of the policy prerogatives that we've been addressing and dealing with on a daily basis. With regard to capacity, we have grave concern for capacity for diversion, but we're also concerned with capacity post-release. Right now, we have a big problem with providing the continuity of care after people have left our facility. The one barrier that I wanted to ask you, if you could talk about, was our state limitations to funding the big three diagnoses. Right now, the state only funds MHMRA to provide for schizophrenia, bipolar disorder, and major depression. Inside the jail, we're giving comprehensive coverage for PTSD, anxiety disorder, but naturally that treatment's for naught when they're released back into the community.
Sure. Well, so, and some of that's a really important question. It's particularly important for some particular subgroups. So veterans, for example, post-traumatic stress isn't on that list, and that's a big barrier. So a little known fact, though an important fact, is the last legislative session that barrier was clarified, that barrier is not there. There is no restriction around the big three diagnoses. What there is there's a traditional funding stream that was designed around the big three diagnoses that was not increased in a way that people sort of perceive as large enough to handle more. So it's at the discretion of local jurisdictions about how much they want to stray from those. And you know, it's sort of like, you ever hear that story about like, you know, Grandma, why do we cut the ends off the ham, you know, every year at Christmas? It's because we had a small pan back in the 50s. Now that we've got a big pan, we still cut the ends off the ham because that's what we do. You know, so a little bit of it is getting out of the mindset, and that's why we think it's really the local system coming together and making decisions around that. I mean, you have $110 million a year more being spent here through your district projects. Did you prioritize any of the district projects around the things we're talking about today? And if not, why? I mean, those are questions I think that can only be answered here in Harris County. And I'm not saying that those other needs that the district projects are addressing aren't important. I'm not saying some of them aren't addressing this population. But I think that you basically have to make the local decision about how to do that, and then you have to operationalize it. And, you know, some of it gets down to two similar protocols. Like one thing Dr. May and I have been talking about is, you know, the ANSA is a protocol that the mental health system needs to use. If there was a way to sort of get the ANSA more used on, I mean, she's doing very comprehensive assessments. It'll take about 10 more minutes at the end of her assessment to put it into an ANSA format. And if we had that in there in a reliable way, that makes a very nice pipeline to get folks over into the mental health system and to help inform and make decisions about that. So I think when we get into, and that's a very functionally driven tool that looks at level of functioning, it's less about diagnosis. So the other thing I'll tell you too is I wouldn't make too big of an issue about this, the big three thing. I mean, it's an issue, but we have to keep it in perspective because, you know, we're doing a study right now of all the adults in the Medicaid system with serious mental illness, and the difference in the number between the big three who have big needs and the others is, I mean, PTS is a big group. But once you get beyond that, it's not that many folks, and most people figure out how to give somebody a qualified diagnosis, frankly. So, I mean, it's really moving to more functioning and local decisions around how to implement.
Teresa, I'm going to cut you off because I promised one more question.
No, go.
Okay.
I'm not saying anything.
I just wanted to ask about, I mean, being a person myself in recovery and dealing with so many individuals in the Harris County jail that have mental health issues along with substance abuse and dual diagnosis. A lot of them that are attending my classes and my groups are so heavily medicated they can't stay awake to program. Is there anybody doing any research in psychotropics that are not addictive and not so drowsy with the drowsy effect? Because it is so hard to work with individuals and work on rehabilitating them, and they're not coherent, and they can't stay awake and alert. And a lot of them use the excuse that, well, they diagnosed me bipolar, so I need a check. And they focus on thinking that being bipolar, ADHD, or ADD is an excuse for me to not have to get a job. And our MHMRA people re-educating or educating for the first time when they're coherent enough that that's why you take the medicine. If you're depressed, you were under the blanket and couldn't come out, and now you're on the medication. Why are you still under the blanket?
I'm going to let my two psychologists answer that.
Well, and, you know, Kathy, you know, we recently opened up reopened the dual diagnosis residential
so excited
facility.
about
And
that.
it's designed to deal with exactly the issues you're talking about. It's designed for this specific population that uses drugs and has serious mental health problems. What is absolutely critical, and several people have hit the nail on the head today, is, you know, we are in a position to provide valuable information to the psychiatrist that we need some medication adjustment, probably,
Yes,
because of those kinds of difficulties. When they're sitting in jail, it's a little bit different, so you need to keep that in mind.
Yes.
But there is the most effective programs for mentally ill, criminal justice involved individuals involve collaboration between the criminal justice partner and the mental health professional. And that is a free-flowing communication, quick acting, and co-educating these individuals and working with them. And it's an everyday thing. My hope is that we get to a point in Harris County where we're going to continue to improve that and kind of break down the barriers.
Thank you so much.
Okay.
Yeah, the only thing I would add is I think we also need to set the goal that to not just have programs to do these things, but to have systems.
I agree.
That we have to have, basically every entry point in our system has to be co-occurring capable. I mean, it's ubiquitous. We have to be able to deal with that at every entry point and every treatment program. And I think that there's great things to model on, but that should be our goal.
I want to thank everybody. Particularly, I want to thank the panel for a great job. I think very educational, very interesting. Thank you, guys. And now I believe we got about a 10-minute break, and that they're supposed to then be in for lunch. And don't miss the next speaker. He's my co-conspirator in a lot of stuff that we did in Texas, and that's my friend John Whitmire.